بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the second part of the topic concerning the high resolution CT diagnosis of diffuse lung disease. In the first part, we have stopped at the pattern, which is known as the ground glass pattern. We divided this pattern into two forms. The acute form, we have finished with the acute form, and we uh, provided the differential diagnosis for the possible acute presentation of ground glass lesions in the lung fields. These include pulmonary edema, whether due to cardiac causes or due to acute respiratory distress syndrome, pneumonias, especially the viral and the HIV-related pneumonia, which is known as the pneumocystis jirovecii or pneumocystis carinii, pulmonary hemorrhage, and acute eosinophilic pneumonia. Then you remember the acute ground glass pattern deals with two types of pneumonias, pulmonary edema and hemorrhage. Then we shift to the chronic presentation of patients with ground glass opacities in the lung, and the differential diagnosis include, the possibilities include the hypersensitivity pneumonitis, the organizing pneumonia, including the cryptogenic type, the bronchoalveolar carcinoma, alveolar proteinosis, and you remember that we have mentioned that these two most common causes of idiopathic interstitial pulmonary opacities, the usual interstitial pneumonia and non-specific interstitial pneumonias, are associated with ground glass patches together with, as you remember, traction bronchiectasis and honeycombing, especially in the usual interstitial pneumonia. And what about the hypersensitivity pneumonitis, and it's also known as extrinsic allergic alveolitis. And this is, from its name, is an allergic lung disease related to the inhalation of a variety of organic or dust antigens. And it is known that more than 200 antigens are associated with hypersensitivity pneumonitis, and this type is divided into three phases: the acute phase, the subacute phase, and the chronic phase. The changes in the lung are in the form of ground glass opacities alternating with areas of low attenuation as well as areas of normal lung tissue. These three opacities or three distributions are related to what is known as the head cheese sign, and this is the meat of the head of the pig, which is smashed into cubes, as you can see here, and this the simulation between both is that here you can see three different colors, and also in the lung and you can see three different colors. Those are the areas of ground glass pattern, the areas of air trap, and the areas of normal lung. And you may feel that there is some way of similarity between both. And hypersensitivity pneumonitis, to be diagnosed, in the patient would have a positive history of exposure to a certain allergen, and this may take a long time to identify the specific antigen. Then you look to the chest X-ray of an asthmatic patient with hypoxia and some infiltratives in the lung by high resolution CT, and you can see the classic appearance of diffuse ground glass pattern with areas of air trap and areas of normal lung, and this is helpful in the diagnosis of hypersensitivity pneumonitis. Then by high resolution CT, you see ground glass opacities, usually in the middle and basal lung zones. You may see some centrilobular nodules, and you see some areas of air trap. You remember that air trapping is better identified in the expiratory phase of high resolution CT, which is not usually obtained as a routine. Then other features of hypersensitivity pneumonitis may include the presence of some mediastinal lymphadenopathies, also enlargement of the pulmonary artery denoting pulmonary arterial hypertension, and emphysematous pulmonary changes which will end in pulmonary fibrosis, especially in the chronic phases of the disease. Then this patient is known to keep birds as a hobby and presented by dyspnea and ankle swelling. The chest X-ray showed the bilateral ground glass veiling of the lung fields with hazy appearance of the hilar shadows. Then the high resolution CT, you can see the extensive ground glass opacities, but here, and you can easily appreciate the presence of traction bronchiectasis and also areas of air trap or emphysematous changes. If you do not know the history of this patient, the diagnosis will be non-specific interstitial pneumonia. But if you know that this patient has exposed to a certain allergen, then you may put into the differential diagnosis the possibility of hypersensitivity pneumonitis. And in the phase where you can see traction bronchiectasis and air trapping, and this should not be the acute phase, but of course the subacute or the chronic phase. In the chronic phase, you got more destruction of the lung parenchyma, more interstitial opacities, more traction bronchiectatic changes. Then, in the subacute phase, the high resolution CT will show ground glass opacities, areas of air trap observed on expiratory phase of the high resolution CT. In the chronic phase, you got fibrosis, and with fibrosis, you may see, of course, traction bronchiectasis, many interstitial opacities, including septal thickening and reticular opacities denoting pulmonary fibrosis. Then we go to one of the types of pneumonia, which is known as the organizing pneumonia and or the cryptogenic organizing pneumonia. This is a disease of unknown etiology and is not associated with smoking. The presentation of the disease is usually between the age of 55 and 60 years of age. And this organizing pneumonia, if it is idiopathic with no known underlying cause, it is known as cryptogenic organizing pneumonia, and it was termed previously bronchiolitis obliterans organizing pneumonia or POP. This is the old name of this disease. This disease is known as organizing pneumonia if it is without any known cause. It is called cryptogenic organizing pneumonia. The presentation is by dyspnea, non-productive cough, weight loss, malaise, and fever. The appearance of cryptogenic organizing pneumonia is usually referred to as this very particular appearance, which is known as the atoll sign. And I will show you what I mean by this atoll sign. If you look here and you can see, this is the most classic appearance of this type of pneumonia, which is known also as the reverse of halo sign. This is the halo sign. You may see a lesion with a halo of ground glass veiling around. But here you see the ground glass veiling inside the lesion, and this is the periphery of the lesion, which is almost similar to this particular appearance of an island. Then the appearances of cryptogenic organizing pneumonia are usually in the form of multiple batches of this reverse of halo sign. They may be unilateral or bilateral. They can affect any part of the lung, and is usually peripheral and subpleural in location. Sometimes the lesions are more than 1 centimeter and may reach up to 5 centimeter, simulating a neoplasm. Then you may got bronchial wall thickening and the ground glass opacities or even the crazy waving appearance. The reverse of halo sign or atoll sign is highly specific for cryptogenic organizing pneumonia. However, it is seen only in 20% of the cases. Then, if you have an chest X-ray like this, and you may feel that this is the reverse of halo sign, and you confirm the diagnosis by high-resolution CT, and you see the central part of the lesion showing ground glass, while the peripheral part of the lesion is more dense and more thick. Then you may think of a cryptogenic organizing pneumonia if you see this finding. One of the very important suggestive findings is the loss of response to multiple courses of antibiotics. You remember with acute eosinophilic pneumonia, I said that if you see multiple patchy opacities in the lung suggestive of pneumonic consolidations and the patient is not responding to many courses of antibiotics, then you may think of one of two. The first one is acute eosinophilic pneumonia and is diagnosed by the presence of eosinophils in the blood picture and eosinophils in the bronchial lavage. The second type of pneumonias that are not responding to antibiotics is the cryptogenic organizing pneumonia. Then this type is diagnosed usually by biopsy. And look here in this patient presented by dyspnea and presented persistent chest radiograph abnormalities, areas of consolidation, in spite of antibiotic treatment. Then the high resolution CT is not actually showing the classic reverse of halo sign or atoll sign, but the positive history of multiple patchy opacities not responding to antibiotics may raise the possibility of cryptogenic organizing pneumonia. Then we have finished by the two patterns. The first one is the reticular or interstitial pattern. The second one is the ground glass pattern, and we divided into two categories, the acute type and the chronic type. Then we came to the third pattern, which is the air space filling or alveolar opacities. Alveolar opacities are known as consolidation, and by consolidation we mean replacement of the air in the alveoli by any other material. And this will result in opaque alveoli and patent bronchi containing air, and this will appear on the chest radiograph as well as on the CT as the very famous sign in chest radiography, which is known as the air bronchogram. By air bronchogram, we mean that we are dealing with a pulmonary parenchymal disease of alveolar nature, and its name is consolidation. And by consolidation, we mean replacement of the air in the alveoli by number one, fluids, and you got the disease alveolar edema. Exudates, you got pneumonia. By blood, you get hemorrhagic pulmonary disorders. By tumor cells, you got alveolar cell carcinoma. By proteins, then you got alveolar proteinosis. As you can see here that these three are diagnosed mainly by the clinical findings, and this one is problematic for the diagnosis. Alveolar proteinosis can be diagnosed easily from imaging. Then you remember that the chest radiograph is the most practical and useful method for assessment of pulmonary edema. And you remember we have two types of pulmonary edema, The interstitial type we finished with the reticular pattern, and the alveolar type, which is seen here. By the alveolar pattern, you got opacification of the lung, both lung fields in a more central pattern, sparing to some extent the periphery of the lung, giving the classic appearance of bat wing configuration. Then you may see air bronchogram, which is not evident here. It is evident in pneumonias in particular. You may see, of course, pleural effusion and the thickening of the interlobar fissures. And then this is what we mean by bat wing configuration. You got pulmonary opacities mainly in the parahilar area. You may see some air bronchogram, and of course, you may get enlargement of the cardiac shadow because of the cardiac disease, which is responsible for this type of edema. And this is also a pulmonary alveolar edema, bat wing configuration on both sides of the enlarged cardiac shadow. You do not need usually the help of CT because the clinical picture is quite evident, and the chest x-rays are usually enough. But if you have the CT scan of the same case and you got opacities, little air bronchogram sparing the periphery of the lung, as you can see here. And this is another example of pulmonary alveolar edema with bat wing configuration. It is known also as the stage 3 left ventricular failure. Remember, stage 1 is enlargement of the hilar shadows with distension of the upper lobe vessels. Stage 2 is the presence of interstitial edema with A, B, C Curly's lines, as I have mentioned. Then stage 3 is the alveolar edema. Then you shift to the pneumonias, and pneumonias are usually diagnosed by the clinical symptoms of acute onset, the presence of fever, cough, and expectoration, and the chest radiographic findings of the presence of dense areas of consolidation containing evident air bronchogram, and the sputum is usually positive for the presence of infective organism. The pneumonia can be seen also by CT, where you can see patchy opacities with air bronchogram. The monic consolidation usually involves the periphery of the lung and the areas of the lung adjacent to the fissures. Then we came to the pulmonary hemorrhage. And pulmonary hemorrhage is one of the causes of alveolar opacities in the lung. Some patients may complain of hemoptysis. They may have anemia because of the bleeding into the lung and the airspace opacities. The opacities usually clear rapidly, but not as rapid as the pulmonary edema. Edema clears more rapid compared to the hemorrhage. For the diagnosis of hemorrhage, you need some of the clinical findings. Number one is to know that the patient may have one of the diseases that may contribute to hemorrhage, like systemic lupus erythematosus, Wagner granulomatosis, any form of vasculitis that may lead to hemorrhage. Number two, and you got opacities which are almost similar to pneumonic consolidation, but with little or no evident air bronchogram. The opacities clears rapidly. Number three, the cardiac shadow is not enlarged, like in cases of pulmonary edema, the heart should be enlarged. Then in this patient with non-systemic lupus erythematosus, and you can see the more central distribution of the opacities, some of the air bronchogram suggestive of pulmonary hemorrhage. And this patient with systemic lupus erythematosus presented by dyspnea hemoptysis and low serum level of hemoglobin. She showed the chest X-ray, the high resolution CT showed multiple uh, pulmonary parenchymal opacities with little air bronchogram. The opacities spur the periphery of the lung, and in the the clinical setting, the diagnosis is suggestive of pulmonary hemorrhage. This patient with Wagner granulomatosis showed bilateral patchy alveolar opacities. And of course, you know that patients with Wagner granulomatosis may develop pulmonary infection as well. And they may present by patchy opacities of pneumonic consolidation. But in cases of pneumonia, you got positive history of infection, you got fever, you got cough, you got expectoration of sputum. In cases of hemorrhage, you may get hemoptysis and you do not have the acute symptoms of pneumonia. So, in patients with Wagner granulomatosis, if you see patchy opacities, you may consider the two possibilities of infection and hemorrhage. Then we came to the alveolar bronchoalveolar carcinoma, which is a malignancy caused by atypical cells, proliferation of atypical cells lining the alveoli and the respiratory bronchioles. The lesions are starts as fine nodular shadows in the miliary pattern, and they later on coalesce to form patches with some internal air bronchogram. The incidence is about 2.8% of the population, and the incidence increases by the increase in the age. The presentation is usually non-specific in the form of cough, sputum, weight loss, hemoptysis, and bronchorrhea. The diagnosis is usually reached by percutaneous biopsy, CT-guided biopsy, or by bronchoalveolar lavage. The radiographic patterns of bronchoalveolar carcinoma include number one, pulmonary nodule or mass with internal air bronchogram. This is very important appearance where you see a well-defined lesion with internal air bronchogram. This appearance have the three differential diagnoses. Number one, round pneumonia, which is common in the pediatric age group, lymphoma, and bronchoalveolar carcinoma. Then and many times you see this appearance, you cannot separate lymphoma from bronchoalveolar carcinoma unless you have a biopsy from this lesion. And then another pattern which is known as the consolidative form, which is exactly similar to a mnemonic patch, which do not respond to antibiotics. Then you put the two main possibilities, lymphoma and bronchoalveolar carcinoma, and you go to biopsy to confirm the diagnosis. The third pattern, which is the miliary pattern, diffuse micronodularity, and this will go into the differential diagnosis of miliary shadows, which will be dealt in the third part of this presentation. The bronchoalveolar carcinoma may have some of the radiographic signs which are not specific for bronchoalveolar carcinoma, like the CT angiogram sign. If you look here and you see a consolidation in the lung, and also you can see the vessels running through the consolidated area, this is known as CT angiogram sign, which is not pathognomonic for bronchoalveolar carcinoma. The crazy paving pattern, which is seen particularly in alveolar proteinosis, may be seen here also. Ground glass opacities and consolidation with air bronchogram, as I have mentioned before. Then this is the consolidative form where you see a patchy opacity which is exactly similar to pneumonia, but the symptoms of pneumonia are lacking. The response to antibiotics is lacking. Then you may think of one of two possibilities, lymphoma and bronchoalveolar carcinoma. And also you may think of some of the other types of atypical infection which do not respond to antibiotics. Then if you have the CT scan and you can see this particular appearance, which is a mass or a nodule or with internal air bronchogram, this may lead you to think of one of three: round pneumonia, bronchoalveolar carcinoma, and lymphoma. But in the presence of these nodules, the issue of round pneumonia is not here, but you think of Number one is the bronchoalveolar carcinoma, because you know that bronchoalveolar carcinoma starts by biliary shadows, and then these biliary shadows will coalesce to form larger shadows, then will coalesce to form patches with internal air bronchogram. Then this is a very important appearance to lead you to think of bronchoalveolar carcinoma. The differential diagnosis may include lung cancer, of course, but the lung cancer has a strong association with cigarette smoking. The lung cancer is typically symptomatic, and it has a higher frequency of lymphadenopathy and metastatic disease. Pulmonary infection, and you got the symptoms of infection like fever, leukocytosis, cough, and the also the response to antibiotic therapy. Lymphoma, there is a great overlap between bronchoalveolar carcinoma and lymphoma, because lymphoma may present as a patchy opacity with internal air bronchogram similar to a pneumonic consolidation, usually seen in immune suppressed patients, and is usually multiple and is usually associated with lymphadenopathy. And pulmonary deposits, of course, you know that deposits do not contain air, bronchogram, and the patient should have a non-primary malignancy. Then if you look here and you see opaque left hemithorax, patchy areas in the right hemithorax, the CT scan showed patchy areas with air bronchogram, some ill-defined pulmonary nodules, areas of consolidation, and the please remember this, the presence of patchy areas with air bronchogram together with multiple pulmonary nodules in the same lung or in the opposite lung may lead you to suspect the possibility of bronchoalveolar carcinoma. And this is the difference between pneumonia and the alveolar cell carcinoma. The pneumonia will show an opacity with internal air bronchogram with peripheral distribution, and there is no nodularities in the same lung or in the opposite lung. But in this patient, then you can see patchy opacities with predominant central distribution, more central distribution, absence of significant internal air bronchogram together with the presence of multiple pulmonary nodules in the same lung and in the opposite lung, which are the precursor of these pulmonary opacities. Then we came to the pulmonary alveolar proteinosis. You remember, we are discussing now the patchy alveolar opacities. We have finished with pulmonary alveolar edema, Bat's wing configuration, the pneumonic consolidation, pulmonary hemorrhage, pulmonary bronchoalveolar carcinoma, and we'll finish by this, which is the pulmonary alveolar proteinosis. This is a rare disease which is relatively common in male compared to females. The age of presentation is relatively young, between 20 and 50 years of age, and the disease will occur due to intra-alveolar accumulation of lipoproteinaceous material, and it is strongly associated with smoking. And the presentation is non-specific by dyspnea and non-productive cough. The diagnosis of alveolar proteinosis is obtained by imaging, as I have mentioned, by bronchoalveolar lavage, by sputum examination, and sometimes you need the help of CT-guided lung biopsy. And we have three types of pulmonary alveolar proteinosis. The autoimmune type, which is the most common, the secondary type, which is less common and seen in individuals with other diseases like hematological malignancies, inhalational lung disease, silicone and others, and immunodeficiency with coexistent infection. The congenital type is rare and is seen in the neonatal period. Then the chest X-ray may show a pattern which is similar to cardiogenic edema, but the heart is not enlarged. The opacities are more or less the same. They are usually basal, near to the central part of the lung, and the air bronchogram is not evident. And this particular disease, pleural effusions are not seen, cardiomegaly is not seen, lymphadenopathy are not seen. Then, if you look to the CT scan and you see the classic appearance of the crazy waving pattern, which is in the form of hexagonal opacities containing ground glass areas together with areas of the lung showing normal density. Then a smooth thickening of the interlobular septal lines with ground glass opacities will produce this classic appearance, which is known as the crazy waving pattern. And pulmonary fibrosis is not typical for adult type, but is more commonly seen in the neonates. In the chest X-ray, you cannot predict the presence of alveolar proteinosis, but you will see diffuse ground glass opacities. You may feel that you are dealing with miliary shadows, and you may also think that you are dealing with interstitial lung disease. Then the high resolution CT will show the classic appearance of crazy waving pattern hexagonal opacities with internal ground glass veiling together with areas of normal lung parenchyma. Once more, the chest X-ray cannot predict the possibility of alveolar proteinosis. All what you see is similar to many of the previously mentioned diseases with ground glass areas and interstitial opacities, but the CT scan will show the classic appearance of crazy waving pattern with sparing of some of the lung parenchyma, diagnostic of alveolar proteinosis. And this is also another example of alveolar proteinosis with crazy waving pattern and areas of unaffected lung parenchyma. هذا وبالله التوفيق. السلام عليكم ورحمة الله.